from University of Pennsylvania, who's going to talk about CART therapy in CLL, the Penn experience.
Yep. Good morning, everyone, and I want to echo the thanks for coming so early in the morning. So I'm going to talk with you today about our experience at the University of Pennsylvania using autologous T cells, which have been genetically engineered to target tumor antigens. Specifically for today's talk, the target is CD19, and the patient population are those with high-risk CLL. So for my introductory slides, I think we had a really nice introduction just now by Dr. Park with the Sloan Kettering experience. So I'll try to go through these slides a little bit briefly. But as we've already heard, as a treatment modality, targeted T cell therapy has the potential to overcome many of the limitations of both chemotherapy and other targeted immunotherapy. It combines many attractive traits of the other immunogenic therapies with the specificity of a targeted antibody, the ability to expand in vivo for an amplified anti-tumor response, and as I'll show later, the persistence of these T cells over time may confer some memory activity with the potential for ongoing tumor surveillance, which is of course the goal of cancer vaccine therapy. So this slide, we actually saw this same slide, but CD19 is an ideal tumor target for CLL. And in general, first and foremost, it's expressed on most B-cell malignancies. And we know that antibodies targeted to CD19 result in an anti-tumor effect. Importantly, its expression is limited to the B-cell lineage, and it's not expressed on hematopoietic stem cells, which means a bone marrow failure syndrome is not expected with this therapy. That being said, it is expressed, of course, on healthy B cells, and B cell aplasia is an expected on-target off-tumor effect of this therapy. So we heard a really nice summary of the CAR construct from Dr. Park, but I'll highlight some of the specific aspects of the CAR product that we're using at UPenn. So of course, with the use of gene transfer techniques at UPenn, we actually use a lentiviral vector as opposed to a retroviral vector currently being used at Sloan Kettering. But the T cells can be genetically modified to stably express antibodies on their surface, which of course confers a new specificity to these engineered T cells. CARs, as we've heard a little bit already, are constructed to combine an antigen recognition domain, in this case anti-CD19, with an intracellular signaling domain. And the intracellular signaling domain is extremely important. It is what allows these T cells to function as endogenous T cells. It's what drives their activation, expansion, and persistence in vivo. So traditionally, the CD3 zeta chain is used in CAR products as intracellular signaling domain. Again, the goal of this is to confer endogenous T cell activity. The UPenn CAR construct that I'll be sharing clinical data with you in a moment employs the use of the CD137 or 4-1 beta-beta co-stimulatory domain, which in xenograft models correlates with a more robust anti-tumor effect and also the persistence of these T cells over time in vivo. So this cartoon, again, similar to what we already heard from Dr. Park, but this cartoon highlights the mechanism of action of these engineered T cells. The first step is manufacturing the cellular product, which starts with the introduction of the CAR construct into the T cell, which in the UPenn experience is a lentiviral vector. The CAR protein with its antigen-specific domain and intracellular signaling domain migrate to the cell membrane and target the tumor cell for destruction. So to date, we've used these genetically modified T cells to treat 32 patients with high-risk CLL. And we did this over the course of 2 clinical trials. The first was a pilot study where we treated 14 patients. The second study is actually still open to accrual. And in this study, we randomized patients to receive one of 2 initial dosing levels and we've treated 18 subjects on this study to date. So shown here is just a cartoon of the main manufacturing and clinical steps that a patient goes through as they are treated with this T-cell therapy. The first step is a pheresis procedure to collect the patient's cells. This cellular product then undergoes several manufacturing and processing steps in our cellular processing lab, which includes the introduction of the CAR construct, again, in our case with a lentiviral vector, and then activation and expansion of the T cells. We also use co-stimulatory coated beads to do that. Before the cells are given back to the patient, all of our patients do receive lymphodepleting chemotherapy. Again, this serves as a goal for both bulky tumor reduction, but also makes the host more agreeable to accept the T cells and allow for rapid expansion. So our first study, as I mentioned, we treated 14 patients. The primary objective of this study was to assess the safety and feasibility of using this technology in patients with high-risk CLL. I won't go through the formal inclusion and exclusion criteria, but these were very high-risk patients with limited prognosis when looked at in the context of available therapies at the time. So again, 14 patients, median age of 66, median number of prior therapies was 4. 6 of them had a p53 deletion. Our protocol did not mandate the type of lymphodepleting chemotherapy to be used, and so 6 used bendamustine conditioning, and the other 8 used pentostatin or fludarabine-based conditioning. So shown here is just an itemized line-by-line description of these 14 subjects who were treated on this therapy. 4 of them developed a complete response, and in these 4 subjects, the complete response has been maintained over time, and 2 of these patients are now over 3 years in follow-up. 4 other patients had partial response. A couple of these patients, this partial response has been clinically meaningful, but the patients meet criteria for partial response because of ongoing detectable lymphadenopathy. Unfortunately, 6 patients had no clinical response. And these are these same subjects rearranged here, just as a way to remind me to share with you that to date, we have not been able to determine a priori clinical predictors of who is going to respond to this therapy and who is not. So the subjects in yellow on top are the responders, and those below are the non-responders. And again, of course, very small numbers of patients. Statisticians would cringe, but if you look grossly at the data, the 2 populations clinically appear to be similar age, similar number of prior treatments, similar incidence of high-risk genetic abnormalities. And in terms of infusional dose of CAR T cells, grossly this was similar in the 2 patient populations. But again, this is a therapy where the infusion of the product might not be the most important aspect because different patients might have different in vivo expansion. And so that was a variable that panned out as being a predictor of who will respond and who will not respond. Those who had a nice response, not surprisingly, that correlated with a more robust in vivo expansion. So the results of this pilot study led to our follow-up study, which again is still open to accrual. And this study randomized patients to one of 2 initial cellular dosing levels. And again, that might not be the key question here, but that's the study that we have open. And this study had as its primary objective the incidence of response rates at 3 months. And again, we've treated 18 patients so far on this study. In the interest of time, I'll show just the summary response data. Overall response rates are similar to that observed in our pilot study. And while this is very preliminary data, to date, we have not observed a dose response or dose toxicity relationship. But again, this is based on the cellular dose initially introduced to the patient. And here just shows a summary slide of the 32 patients with CLL we've treated to date, again, including complete and partial responses, an overall response rate of 47%. So our clinical responses, there are two types of responses that we've been very excited about. Shown here is a patient who had a very rapid initial response with complete eradication, even with deep sequencing investigational minimal residual disease techniques at their day 31 marrow. This, however, the more exciting part, at least in my mind, is that this patient is still in a remission 3 years after receiving the T-cell therapy. Another exciting, very exciting type of response is a little bit more slow and indolent. So here, shown here is a patient who, as you can see, had very bulky lymphadenopathy, heavily pretreated, actually a younger patient in his 50s, 17p deletion, had at this point in the natural history of this trial, ibrutinib was available in clinical trial setting and had even had radiation therapy. And as you can see, this patient is one of our partial responders. However, this actually would extend out to month 6 now, has had ongoing reduction of his lymphadenopathy without any intervening chemotherapy. So biological correlates to these two clinical scenarios where we see sustained remissions and ongoing potential for anti-tumor activity correlates with the biological information I show here, which is that in the top row, from 1 year to 3 years out, we see detectable CAR cells in the periphery. And a functional correlate of this is B-cell aplasia, an expected on-target off-tumor effect. And as you can see, this same patient does not have healthy B cells 3 years later. So unfortunately, in our experience, even in the CLL patient population, this therapy has not been without significant toxicity. We have not observed acute infusional toxicity. This has been very well tolerated. We give the cells peripherally or centrally in the outpatient setting. But what we have observed, which I agree with Dr. Park, is much more dramatic and robust in the ALL patient population, we have observed clinically significant cytokine release syndrome, which we nickname CRS, in the CLL patients as well. And I'll talk more about that in one moment. We already talked about B-cell aplasia. This we see. We've been treating patients with replacement IVIG for their corresponding hypogammaglobulinemia. And to date, although follow-up is extremely short, just over 3 years for our longest patient out, we haven't seen a correlative clinical increase or severity of infections. Tumor lysis syndrome has been sort of what we think of standard clinically and easy to manage so far. So a little more about the cytokine release syndrome. This is the clinical syndrome associated with high fevers, and patients basically feel like they have a really bad case of the flu. They're miserable. We walk into the room, we smile because we know the T cells are working. They look at us and with daggers in their eyes. So unfortunately, this flu-like syndrome can develop to be more clinically significant with end organ dysfunction, hypotension, requiring oxygen, and high-level ICU support. The onset of the cytokine release syndrome has been pretty variable across different disease types and different patients. Might be related to the extent of in vivo expansion or tumor burden circulating cells in the periphery. But the onset has occurred anywhere from 2 days to a couple weeks out from receipt of T cells. We have performed correlative cytokine levels as patients go through their CRS, and one thing that we've observed is that very high levels of IL-6 is observed. The patients can develop a very clinically severe CRS syndrome, which mimics HLH or macrophage activation syndrome, and we've observed very high correlative ferritin levels as this process gets worse, and hemophagocytosis have been observed morphologically in the bone marrow and on liver biopsies. With the high IL-6 levels observed, we've actually, several patients started to use a drug called tocilizumab, which is an anti-IL-6 directed antibody. It's actually FDA approved to treat rheumatoid arthritis. And this has been very dramatic in shutting down the CRS in our patients. Shown here is a fever curve. The x-axis is on the modality of hours, and you can see within hours of receiving tocilizumab, the fever curve drops, and this correlates with other clinically significant adverse events happening to the patient at the time. And shown here is just a similar curve showing, these ferritins are very high. This was a CLL. No, this was an ALL patient. But showing that administration of tocilizumab results in a marked reduction in the ferritin level as well. So this is a very effective drug to shut down the CRS, and it does it very rapidly. What we don't know is whether shutting down the CRS, it's so good at shutting down those T cells, is that having a major impact on the anti-tumor effect of these cells. And so clinically, we wait for patients to be a little bit sick before we administer tocilizumab. So what we've learned is that there's massive in vivo expansion in the CLL population when lymphodepleting chemotherapy is used. We have seen the eradication of bulky tumors in some patients. Excitingly, we've seen these CAR cells persist for over 3 years in some patients. Most of the responding patients do develop a CRS. Unfortunately, some of the non-responders also develop a CRS. Again, an open question is whether early treatment of CRS may abrogate the response. And we've talked quite a bit about how responding patients have, developed B-cell aplasia. So what is beyond the scope of this talk is how CAR therapy fits into other now more available and exciting therapies to treat CLL. And I mean no offense to the other elephants in the room. There are quite a few, which is very exciting for CLL therapy. And so what I think we do know, however, is that CAR therapy has a real future in CD19 positive malignancies. Dr. Park talked about the future of developing even better CAR constructs. And on the clinical side, which is where I live, I think we are going to get better at delivering these T cells to patients, both initial dosing level, maybe multiple infusions, and along that line, managing the toxicity. I think we have a lot to learn there. And again, I just want to thank many people at UPenn and many of the supportive industries in this venture, and of course the study participants, who we are all greatly indebted to.